Okay, welcome everyone to this deep dive. You sent over some really interesting material on endodontics.
Yeah, endodontics. Most people probably know it better as root canal therapy.
Exactly. That's the phrase that usually pops into mind, root canal. So today, we're going to dig into that. Look at, when it's needed, why it's needed.
What the procedure actually involves, what to expect.
Yeah, what to expect, and also, maybe just as important, when it's not the right call.
Mm-hmm. Crucial distinction sometimes.
Our mission here is really just to pull out the essential info from the sources you shared, give everyone listening a solid, practical understanding.
Without getting bogged down in, super dense medical jargon.
Precisely. Just the key takeaways.
Sounds good. It's definitely a topic that can stir up some anxiety for people, so having clear info is always helpful.
For sure. Okay, so let's start at the beginning. Endodontics, what exactly are we talking about here?
Well, the material makes it clear it's a specific brand of dentistry that deals with the tooth pulp.
The pulp, that's the inside stuff.
Mm.
Nerves, blood vessels.
Exactly, the living tissue inside the tooth.
Mm-hmm.
And it also covers the tissues right around the tip of the root. They call those the periapical tissues.
Periapical, got it.
And like you said, the main treatment everyone links with endodontics is root canal therapy, or RCT for short.
RCT. Okay, so when does a dentist actually recommend RCT? What are the indications?
Not the why. The sources you sent point to a few main things. Big one is gross inflammation inside the tooth.
Just really inflamed pulp.
Yeah. Or if the tooth is necrotic.
Necrotic.
Basically, the pulp tissue has died.
Okay, dead tissue inside. Makes sense you'd need to deal with that.
Definitely. And another key factor, really important, is whether the tooth is actually restorable after the root canal.
Ah, right. No point doing the procedure if the tooth will just crumble afterwards.
Precisely. You need enough sound tooth structure left to put a filling or a crown on top and have it last.
It makes total sense. What else?
The other major trigger is exposure of the pulp.
Like the nerve is actually showing.
Yeah, or very nearly. This can happen because of deep cavities. The sources use the term carious exposure.
Carious, right, from decay.
Or it could be mechanical, like if the tooth gets cracked or broken.
Ouch.
Or even from trauma, like getting hit in the mouth.
Yeah.
Anyway, the pulp gets exposed or badly damaged.
Okay, so those are the main reasons for recommending it. But what about the flip side? When is it not the right move? The contraindications.
Good question, because it's not always the answer. Even with pulp problems, the materials highlight excessive loss of tooth structure as a big one.
Too much tooth missing.
Exactly. Whether that's from, say, a really bad break.
Trauma again?
Yeah, or just massive decay that's eaten away most of the tooth. If there isn't enough left to reliably rebuild.
Then the root canal itself won't save the tooth long term.
Right. Another thing is if the tooth is, way out of position.
Yeah.
Severely mispositioned.
Why does that matter?
It can make it incredibly difficult and maybe even impossible for the dentist to actually get their instruments into the root canals to clean them properly. Access is key.
Ah, okay. Physical limitations.
And finally, a really important one is lack of periodontal support.
Meaning the gums and bone around the tooth.
Yes, essentially excessive bone loss around the tooth. If the foundations are weak, even a perfect root canal won't help because the tooth itself doesn't have enough support to stay put.
So even if the inside is fixed, if the outside support structure is gone, game over.
Pretty much, yeah. It wouldn't be a predictable long-term solution.
Okay, so we've got the dentist's view, the clinical reasons for yes or no. But what about the patient? What might someone listening actually feel or notice that could point towards needing a root canal?
Right, the signs and symptoms. The sources list several common ones. Spontaneous pain is one, like pain that just starts up on its own. Or intermittent pain comes and goes.
Not necessarily triggered by anything specific.
Exactly. Also, just severe pain. That's often a clear sign something's wrong inside.
Hard to ignore severe tooth pain.
Definitely. Then there's lingering pain, specifically after having something sweet or hot or cold.
Lingering is the key word there, right? It doesn't just flash and go away.
Right. If you drink something cold and the tooth hurts intensely for, 30 seconds or more after the cold is gone, that's a classic sign of irreversible pulp damage.
Okay, that's a really specific one to watch for.
Yeah. Also, pain or maybe swelling when you just touch the tooth or the gum around it, that's palpation sensitivity.
Tender to the touch.
Or pain when you tap on the tooth, that's percussion sensitivity, or when you're chewing, mastication.
So biting down hurts.
Yes. And interestingly, the sources also mention swelling. That can happen without any pain.
Really? Swelling but no hurt.
It happens. Could be a sign of a chronic low-grade infection, maybe.
Ah.
And finally, something the patient wouldn't see, but the dentist would, on an X-ray.
The radiograph.
Yes. A dark spot, technically called a radiolucency, at the tip of the root, usually indicates infection or changes in the bone there due to the pulp issue.
Wow, okay. Quite a range of potential signals, from obvious pain to subtle things, even things only visible on an X-ray. So if someone shows up with some of these symptoms, how does the dentist figure out for sure, yes, this needs a root canal? What's the actual examination like?
It's a systematic process, usually. The sources outline the key steps. First, there's palpation, like we mentioned, gently pressing on the tooth and gums to check for tenderness.
Feeling around the area.
Then thermal testing. That's the cold test usually, sometimes hot. Seeing how the tooth reacts. Does it hurt? Does the pain linger?
Yeah, I've had the cold test. It definitely gets your attention.
It can. For front teeth, they might use transillumination.
Shining a light through it.
Exactly. Shining a bright light through the tooth to see if it looks different, maybe darker or opaquer than the teeth next to it, can indicate a problem inside, like dying pulp tissue.
Clever.
Another technique, especially useful for upper teeth where pain can be tricky to pinpoint, is selective anesthesia.
Numbing them one by one.
Basically, yeah. Numb one tooth, see if the pain goes away. If not, numb the next one. Helps isolate the culprit.
Like a process of elimination. Smart.
Then there's checking mobility. Is the tooth excessively loose? That could signal infection spreading to the supporting bone or significant bone loss already.
And checking how wiggly it is.
And finally, they might use an electronic pulp tester.
What does that do?
It sends a very mild electrical current through the tooth. Based on whether you feel it and at what level, it helps assess if the nerve tissue, the pulp, is vital, alive, and responsive or not.
So it's a whole battery of tests, really, combining the patient's story with these clinical checks.
Exactly. It's about putting all the pieces together for an accurate diagnosis.
Okay, let's shift to the procedure itself. One thing often mentioned is the dental dam. Why is that piece of rubber so important?
Oh, the dental dam is absolutely critical for modern endodontics. The sources you shared are clear on its benefits. Number one, visibility. It isolates the tooth, keeps the tongue and cheeks out of the way, gives the dentist a much clearer view.
Makes sense. Better view, better work.
Precisely. Number two, and this is huge, infection control. It prevents saliva, which is full of bacteria, from getting into the tooth while it's open. Decreased moisture contamination is the term used.
So it keeps the working area sterile, basically.
As sterile as possible in the mouth, yeah. Before dental dams were common practice, contamination was a major reason root canals sometimes failed. Using the dam drastically improved success rates. It was a game changer.
Wow. Okay, so cleanliness is key.
Absolutely.
Well,
It also protects the patient. It stops any of the irrigating solutions the dentist uses, which can be, caustic.
irritating stuff.
Yeah, stops them from contacting or irritating the rest of the mouth.
It's a good safety feature.
And another safety aspect.
Yep.
It prevents the patient from accidentally swallowing or inhaling any of the tiny instruments or debris.
Okay, yeah, that's definitely important. Don't want to be swallowing tiny files.
Not ideal, no.
Yeah?
So visibility, infection control, patient protection.
Mm-hmm.
The dam is essential.
Got it. Now, we often just say root canal, but the materials mention different types of endodontic treatments. It's not always the same thing.
That's right. It's more of a spectrum, depending on the pulp's condition. The sources detailed several. First, you have procedures called vital pulp capping.
Vital meaning the pulp is still alive.
Yes, exactly. The goal here is to try and keep it alive and encourage the tooth to form more of that hard tissue layer, the dentin, to protect itself.
Trying to avoid the full root canal.
Correct. There are two main types mentioned: indirect pulp cap and direct pulp cap.
Okay, difference being.
Indirect is when the decay is really deep, super close to the pulp, but not quite exposed. The dentist might actually leave a tiny bit of the affected but not infected dentin right over the pulp area.
Leave some decay. That sounds counterintuitive.
It does a bit, but the idea is not to risk exposing the nerve. Then they place a medicated layer, often calcium hydroxide, over that spot, and then a filling. The medication encourages the tooth to form reparative dentin underneath.
Sort of stimulating the tooth to heal itself?
That's the goal. Direct pulp capping is when the pulp is actually exposed, maybe accidentally, during decay removal. A tiny exposure.
Oops. Yeah.
In that case, the calcium hydroxide is placed directly onto the exposed pulp tissue, then usually a temporary filling. You wait and see if the tooth recovers without symptoms. If it does, you can place a permanent filling later.
So both are attempts to save a live pulp. Interesting. What else? Pulpotomy was mentioned.
Right, pulpotomy. This involves removing the pulp only from the crown portion of the tooth, the top part you see.
Just the top, not the roots.
Correct. leaving the pulp tissue inside the root canals intact and hopefully healthy. This is commonly done on primary teeth, baby teeth. Remove the coronal pulp, place a medication, put on a crown or filling.
Okay, for kids' teeth.
But it's also used sometimes in permanent teeth, particularly immature ones.
Teeth that haven't finished growing.
Exactly. If an immature permanent tooth gets decay or trauma affecting the pulp, a pulpotomy removes the inflamed tissue in the crown, but leaves the root pulp. This allows the root to continue developing fully for the tip, the apex to close. That process is called apicoectomies. Apicoectomies, root generation, basically.
Kind of, yeah, finishing the root formation. The sources even mentioned doing this, apicoectomies via pulpotomy, sometimes on mature teeth, if the root apex never fully formed for some reason.
Huh. Okay, so pulp capping tries to save all the pulp. Pulpotomy saves the root part. What's the full procedure then?
That would be the pulpectomy. That's what most people mean when they say root canal treatment.
Pulpectomy, got it.
This means the complete removal of all the pulp tissue from both the crown and all the root canals.
Cleaning everything out.
Everything. The sources emphasize using specialized files and instruments to get down into those narrow canals. And a key part of this is debridement.
Debridement.
Just means the thorough cleaning and removal of all the dead, infected, or diseased tissue from inside the canals. Super important step. Makes sense. Got to get all the bad stuff out.
Absolutely. And then finally, there's apicoectomy. That sounds more involved. It is. It's a surgical procedure.
Surgery on the tooth root.
Yes. It involves surgically accessing the very tip of the root, removing that tip, and also cleaning out any infected tissue around the tip and the bone. The sources mention curettage alongside this.
Which?
Basically scraping away the diseased tissue from the bone around the root tip. It's part of cleaning up the infection.
Okay.
And sometimes after an apicoectomy, they do what's called a retrograde root canal procedure.
Retrograde. Like backwards?
Sort of. They place a small filling right at the cut end of the root tip, sealing it off from the bottom up, you could say.
Wow. That's intricate work, operating on the tiny tip of a root.
It really is. Requires a lot of skill and precision.
So yeah, definitely a wide range of treatments under the endodontics umbrella, from trying to coax the pulp to heal, to partial removal, to complete removal, all the way to surgery on the root tip itself.
Exactly. It's definitely not just one single thing called a root canal. The approach depends entirely on the specific diagnosis and the state of the tooth and pulp.
Well, this deep dive has certainly clarified a lot for me, and I hope for everyone listening too. We've covered, the when and why of root canals, the contraindications,
The symptoms someone might experience.
how dentists diagnose the need for it, that crucial dental dam.
And yeah, this whole range of different endodontic procedures.
Some real aha moments for me were definitely understanding those pulp capping techniques, the idea that you can try and help the tooth heal itself first.
Yeah, conservative options are always explored first, if possible.
And also just getting clear on why a root canal might not be the answer sometimes, like if there's not enough tooth left or the bone support is gone.
Right. Understanding the limitations is as important as understanding the procedure itself. It's all about predictable, long-term success for the tooth.
Absolutely. The level of detail and care involved in managing that tiny bit of tissue inside the tooth is pretty amazing when you think about it.
It really is complex.
So maybe a final thought to leave our listeners with. Considering all these intricate steps involved, both by the body trying to maintain the pulp and by the dentist trying to treat it, what other proactive things, maybe in just your daily oral care routine, could further minimize the chances of ever needing endodontic treatment in the first place?
That's a great point. Prevention.
Yeah, think about how overall mouth health connects to keeping each individual tooth's pulp vital and healthy for the long run. It really highlights how interconnected it all is. Thanks for joining us on this deep dive today.